Welcome to the Healthier You Show, a guide to living a healthy, active, and productive life. Today we have a very special guest here with us, Dr. Eddie Teng, anesthesiologist at Long Beach Memorial. Alana, my co-host, and I are going to pick Eddie's brain on labor pain management. Eddie, welcome.
Oh, thank you. Thank you for having me. I'm happy to be here.
Thank you so much for joining us. So let's just first start about, you're an anesthesiologist. Can you just kind of explain the field of anesthesiology and what you do?
Well, anesthesiology is a study of medicine that basically founded on pain relief for surgery and after surgery as well. And we're also responsible for the safety and the care of the patient during surgery and immediately after surgery.
So you have an interesting subspecialty, though. You're an obstetrical anesthesiologist.
Hold on, what is obstetrical? Can you explain that a little bit?
Sure.
It's hard to pronounce.
And, well, one reason you probably don't know is because it's actually a relatively new field. It's actually the specialization of pain management during the peripartum, or the time around birth, pain management for the mother during that period. So we specialize in that specific type of anesthesia.
Can you kind of just explain what that additional training looked like to get that subspecialty designation?
Sure. Well, like all physicians, we go through 4 years of medical school after our 4 years of undergraduate work. And then after the 4 years of medical school, we do another 4 years of training in general anesthesiology. And that would involve putting people to sleep for routine surgeries and such. Then I personally elected to do another year of subspecialty training in the obstetrical field because I was very interested in it. And there we, focused on patients who are mothers-to-be, patients who are laboring and maybe had some complications with their pregnancy and things and such of that nature.
Great. So today, we're talking about pain management during labor. So let's just kind of dive into the field of labor analgesia.
Yes, analgesia. Yes,
I got it. So
got
exciting.
It correct. Yes.
So if you can kind of just explain what that is.
Well, labor analgesia is just a broad term to define the medicines or even procedures we use to help with labor pain. So actually, interestingly, one of the very first anesthetics ever performed in the 1800s was by an obstetrician named James Simpson, and he discovered that chloroform could be used during labor to help alleviate the mother's pain. And he was so successful, in fact, that Queen Victoria of England asked him to perform the anesthesia for her for 2 of her children. So
isn't chloroform the stuff that you always see in the movies, like people running around, they put a towel on their face,
yes,
and they just pass out like that?
Well, yeah, that's anesthesia. There you go.
Right.
That's a simple form of anesthesia.
Exactly. Right, and I mean that was really the basics of anesthesia. I mean, we didn't. The field of anesthesia was very new at that time, and people were just kind of experimenting with different chemicals, and they found that chloroform, which is popular in England, was used, and it could induce anesthesia, and people could go through surgeries or even labor without feeling any pain.
So have we advanced since that point?
All right. Quite a lot has changed in medicine, along with anesthesia. Actually, the modern labor analgesia can be sort of divided into 2 categories. We can divide it into medications that we can give to mothers, either by mouth or through the IV. Or through procedures that we can do. Typically, we call them neuroaxial procedures. And neuroaxial procedures basically are procedures that involve the spine. And basically, it's almost like everybody's sort of been to the dentist before and they numb up your teeth, right? It's sort of the same idea. We use the same class of medications, but instead of giving it to your gums and your teeth, we give it through the spine. And the sensation that the anesthesia causes is very much the same, except it's in the belly and the legs.
So I know epidural, I've heard everyone kind of talk about that.
Sure.
So what is epidural?
Yes.
That's my question.
Yeah.
Right, everybody thinks epidural and all they think is big needle back. And
Yes.
it's quite a scary, thought. But actually, epidural is probably the safest technique we can do's today to help with labor pain. And it's probably the most common choice physicians use in terms of managing pain.
So when you administer that epidural, exactly, I am anticipating I'd feel numbness from basically the waist down, or what is that sensation that I would be feeling?
Sure.
Hopefully no pain.
Right. So there's different degrees of pain control with an epidural, and typically, if you're, say, in labor and you're desiring a vaginal birth, natural birth, we don't numb you out too much because we want you to be able to push. We want you to be able to, when it comes time to deliver, be able to have the strength and the motor strength to be able to deliver. So we give typically most, I'm speaking generalities, and of course, different hospitals sort of have different cocktails and medications they give, but we don't want to give too much medication to the point where you can't move at all, and that's usually sort of works against you. So typically you just get sort of a numbing feeling, but you're still able to move your legs. They may feel a little heavy. Really the best description is it's like if your legs fell asleep, if you've sat in a long position for a very long time, you can't move your legs, or you can, but they just feel weird, and that's sort of the sensation you're going to get from an epidural.
Eddie, you talked about labor and pushing and etc. It's just hard for me to picture them together as a man working in women's health. Tell me, a little bit about the inside stories. Is it really fun, and what is it like?
So there's a joke in anesthesia. We are either neck up doctors or back doctors. So we don't ever go. We never very are down, seldomly down in that area. We specialize looking at the back, doing the epidural, and usually when we place the epidural, it's not the time when they're going to be pushing. It's going to be before it's time to push. It's going to be maybe an hour or many hours before, whenever the mom feels pain and they want some relief. So typically, if they are pushing, it's probably too late to place an epidural at that point, and we're never really involved in the actual delivery. Now, we may be involved in delivery if, say, mom has a very complicated medical history, and we're worried that the delivery puts her in danger, and so we may be on standby to help with any situation that may arise. And many people think anesthesiologists just take care of pain, but we also, again, manage the safety of the patient, and that's actually one of the major crutches of our specialty.
So you're talking about, sometimes in a complicated labor and stuff, you may have to step in certain areas. But I was just wondering if you could just even talk about getting an epidural. What are some of the potential risks that you may take on in getting an epidural? Obviously, the advantages, you're assuming no pain, but
right.
or less pain.
Yeah, it's easy to talk about the risks before, because when you're in labor pain, all you care about is the advantage, and you can spew off all the risks, and the mother's be like, yeah, sure, I'm gonna get it. But the risks of any procedure, there's definitely always risk, and one of the most common risks, and probably all mothers will experience this after getting an epidural, is low blood pressure. Getting an epidural will drop your blood pressure, and dropping your blood pressure is significant because your baby gets all its nutrients from your blood, and if your blood pressure drops too low, the blood won't perfuse to the baby, and therefore that can endanger the baby itself and the mother as well. So we, after placing an epidural, our nurses and myself and other anesthesiologists would very vigilant about checking the blood pressure, maintaining that blood pressure, and making sure that it stays up. And if it does drop, we can correct it immediately, so before any harm could happen. So that's probably the most common side effect and risk. But again, we have methods of dealing with it, so it doesn't usually become a problem. But anytime we use a needle to puncture the skin, there's risk of bleeding, there's risk of infection, but those are very small risks. I think what bothers most people is the fact that they're worried about their spine, they're worried about a needle beat by their nerves, and that really scares most people. And actually, nerve damage or nerve injury is probably the rarest side effect or risk. So that's as long as you have an experienced anesthesiologist who knows what they're doing, that's just not something we even really talk about. Another thing you may, if you do some research on your own and read about on the internet, is spinal headache. You'll hear that term thrown out pretty loosely. Spinal headache is a complication of the epidural procedure. Typically, if it's a headache that appears maybe about 24 hours after the procedure, and it's something that can be corrected if it's very bothersome by the anesthesiologist if need be. But that's something, if you do go on the internet and Google it, you're gonna see that.
MD.
That's gonna be like one of the risks, and that and back pain or nerve damage, things like that. The scarier stuff. But those things are actually quite rare.
What is the most popular or most common type of labor anesthesia?
Epidural, yeah, epidural, again, it's been shown that that's right now the safest way we can control labor pain. Now, obviously there are other ways. Before the advent of epidurals, we've been controlling pain by giving IV medications, IV, like such as morphine, and pain medications. So that can be also used, but the downside of using IV pain medications is it goes into your blood, therefore it goes also to your baby. So the baby will also get some of that pain medication, and some mothers find that that they don't want that.
And so after you've had your baby and stuff like that, just talking about having these medications in your system, is there any issue with breastfeeding immediately after, or is that just not an issue?
Well, typically some of the medications can cross into the breast milk. For medications relating to the epidural, it's probably unlikely, just because the medications we use in the epidural they're called local anesthetics, and they stay locally.
Right.
They stay locally in the spine, and they slowly get absorbed into the blood, but it's just that slow, that speed of absorption is so slow, then it just becomes very small trace amounts in the breast milk. It's not one large dose into the bloodstream where you can see a large dose. IV pain medications tend to have a little bit more that can be transferred to the milk, but it's pretty negligible. It's not really something that we worry about.
How should future moms decide whether or not they should use labor anesthesia, or which type to use?
Sure. Well, that's always a discussion with the mother, the obstetrician, and the anesthesiologist who's taking care of everyone. The labor analgesia is obviously a totally elective procedure or even treatment. Many women have been doing it for thousands and thousands of years without pain control. It's not something necessary.
Right.
So, but some mothers don't want to feel pain, and they can make that decision if it's appropriate for them to have it, meaning they don't have any contraindications to the procedure, such as an epidural. They can just ask for it, and they're allowed to.
And so that's one of my other questions. A lot of times, women talk about how they want to go into the labor and have a completely natural, birth,
Sure.
no use of like any pain medications or anything like that. But once they start, actually feeling those contractions, it's like, get me the epidural.
Sure.
So I guess, is along that line, though, is there a point at which you can't administer medication? And even if someone walks into the hospital and says, I don't want medication, do you guys still do a visit just to kind of discuss their options ahead of time?
Personally, we don't. In my experience, we don't. But certain other hospitals have different sort of protocols and ways they do things. But we, as anesthesiologists in my institution, we don't go unless they ask for it. And I think a lot of mothers are afraid to ask because they feel like if they ask for it, they're going to be pressured into it. And that's something I want to make very clear, is that we're not really there to pressure you to get it. We're there to talk to you about it first. And the decision is, if you're able to receive one, is really up to you. Again, like I said, they've been doing it for thousands of years. You guys, without it, the decision's up to you. And we're there to answer any questions that you may have. If you're scared of any of the risks, things that you've Googled beforehand and you want to clarify,
You have the 9-month time frame to do the homework.
Yeah, and believe me, some of these mothers are very well educated in terms of their pregnancy, and so we invite that discussion. We want mothers to come and talk to us, and we want them to alleviate any of their concerns. And hey, after the conversation, if they say, hey, it's not for me, we're okay with that. You know, that's the decision we really leave up to the mothers. Yeah.
And speaking about epidurals, I know that there's another type. Is there a type of walking epidural?
Sure.
And what is that all about?
So the walking epidural. So there's some controversy in terms of in the past that epidurals can slow down your labor, and you know, so some people have devised a walking epidural. So an epidural that's light enough so that you can actually walk. Because typically, when we administer a regular epidural, you get pretty numb. Although you can still move your legs, they become quite weak, and if you do decide to walk, you could fall, and that's, you know, so you're pretty much bedridden after you get an epidural. So some anesthesiologists divided cocktail medications that allow women to feel and walk, but take care of some of the pain. Obviously, it's a much lighter dose of the local anesthetic. And it's actually made up of mostly pain medications. That's the stuff that we use in the IV. We can actually put it into the epidural as well. And that won't affect your motor strength. And the walking epidural is a choice, but it only works for certain types of mothers. I mean, I think some mothers have expectations that with the walking epidural, they won't feel any pain as well, but that's unfortunately not the case because we have to lighten it up.
So with an epidural, I know you said that you're not going to be completely pain-free. Can you kind of maybe on a scale of 1 to 10, or kind of offer some kind of
Reference.
Sure.
Kind of greater understanding of what that expectation should be.
Right. So actually, yeah, the scale of 1 to 10 is exactly what we use to sort of grade a mother's pain. So typically, we ask mothers before they receive the pain management what their pain is, and usually it's about an 8 to 10. So we ask them, and then we'll do the epidural. Now, let's say we do a straight epidural. Typically, their pains, will go down to a 2 or none. Epidurals are very effective in relieving labor pain. It's the most effective means we have, and you can compare that to. I mean, I'm giving rough numbers, but people who get IV pain medications, they're not going to give you I don't feel any contractions at all type of response. They're going to say, I feel it, but it's much better than before, but I still feel the cramping, the sharp pains, but it's better than before. And that's the other option as well.
Okay, interesting. So I know in some cases, obviously not everyone is lucky enough just to have a natural delivery.
Right.
So in the case where you have, cesarean section and stuff, what are the different type of medications that are involved with that, and what would your sensation level be, like alertness and all those things that go into C-section?
So typically we like to do cesarean sections with neuraxial technique. I mean, the obvious opposite, what we else can do is a general anesthesia, where you put someone to sleep completely. And going to sleep completely under general anesthesia when it's not necessary puts a mother at increased risk. And typically we don't want to put mothers to sleep, especially for a cesarean section. One of the risks also is that the general anesthesia could affect the baby as well and put the baby to sleep. So when the baby is born, they're anesthetized as well.
Right.
So that's something we want to avoid. I mean, it's nothing extremely dangerous, but we just don't like to do that. So we typically like to do these cesarean sections under a neuraxial technique. We talked about epidural, but there are other procedures under that category, and those include spinal and then the combined spinal epidural. If the mother is going to C-section and has nothing, meaning they never got an epidural or anything, typically we give a spinal, which is a much denser, provides a much denser block, a much stronger surgical block that they can basically not feel any of the surgery. But the mother will be awake. So the nice thing about that is, though, the mother's awake, they can see the birth of their baby, and they can hold their baby, and so I think it's a very, very good thing. It's a plus in that situation.
What is the most common complication of anesthesia that you come across?
Well, the most common side effect, again, what we worry about is low blood pressure. I mean, some of these medications can really affect the hemodynamics of the mom, and again, we worry about the blood pressures. We which can, in the end, affect the baby and both the mothers. So that's probably the most common side effect. Some of the medications we put in to the spinal or epidural include the pain medications I sort of mentioned before, and those can cause a little bit of nausea and itching as well. So you'll hear some mothers report that if they receive those types of medications. And usually that's what I tell my patients, like, hey, you may feel nauseous, you may feel itchy, and you're going to feel that blood pressure cuff keep squeezing because we need to know your blood pressure.
So when you talk about that blood pressure cuff squeezing, what does it look like? What does the process look like? Do you keep monitoring every 3 minutes, 5 minutes?
Sure.
Paint me that picture.
Yeah, so typically, I mean, each hospital has sort of their own protocol, but what I personally like and what I usually recommend to my floor nurses if they ask is, please take a blood pressure every 3 minutes for the next 15 or so minutes, and then from then on you can space it out to every 5 to 10 minutes or every 15 minutes, and then we do that for about an hour, and then after an hour you can do it every half hour or so, and you can lengthen it as it goes along, because usually we'll see the drop in blood pressure if there is one, pretty immediately, but eventually the mom sort of kind of gets used to it, so their blood pressure kind of stabilizes over time, so we don't have to check it as frequently now. But anytime we add more medication to the epidural, an additional dose or anything, we go back to checking it again pretty religiously. Yeah.
So now let's backtrack to the beginning of the process. When do you start that procedure? Half an hour before labor, an hour, a couple hours, or when the water breaks?
So start yelling.
So there used to be some, people thought there were some rules in when we should place the epidural because they thought that maybe the epidural could slow down labor, which actually has been shown to be somewhat untrue. So in the past, it used to be like, oh, you had to wait till they're after 6 centimeters dilated or such, and but now the recommendations are whenever the mom wants the epidural, they can ask for one. So they can even ask one before they even have pain because they're coming for an induction, meaning they're coming for stimulation of labor. They can ask for it before so they don't feel anything at all. They won't even get like one inkling of labor pain. Or they can ask for it way later. They want to feel it, And I've had mothers who come in and say, "I want to feel what it feels like to be in labor, but then I don't really want to feel it for the entire time. So after I feel, let me get the epidural." So and then there are mothers, of course, like they can't deal with it. I gotta get it. So they can ask for any time they want. And I again, it depends. And I urge moms to have conversations with their doctors, with the anesthesiologist. Just because you speak to one doesn't mean you have to have it, So talk to your anesthesiologist, talk to your obstetrician, see when it's the appropriate time for you to get it. Don't make this decision just be like on your own. You have those resources. So.
How quickly does it kick in?
Couple
minutes, 5, 10, 15 minutes, 30 minutes?
Right, so a traditional straight epidural, it depends what medication we put in, but traditionally if in our institution we use a medication that takes about 15 to 20 minutes to start, but we actually don't do only straight epidurals at our institution. We do something called a combined spinal epidural, which is the spinal block plus an epidural block. And the spinal block's onset is quite fast, it's pretty much immediate. And then so we leave a catheter with the epidural, and once that spinal block wears off, the epidural catheter can be used to continuously administer medication for as long as the labor lasts and keep the mom comfortable.
So let's not sugarcoat things. I know the epidural has a huge needle. If your husband or partner is afraid of needles, is that a good time to tell them to leave the room? So you don't want anybody fainting on the floor?
Sure.
Have you seen that?
No, I've heard stories. I've heard dads going to the ER, which is unfortunate because they're there to see the baby and then they're in the ER. But so in our institution we have everyone leave the room. One, because of sterility issues. The fewer the people in the room, the less likely for infection. But two, also, we do hear some cases that other family members may be
Double surprise.
Yeah, actually, they faint at the sight of needle. They faint at the sight of maybe a little bit of blood. So we definitely have them in our institution. We have them exit the room. But different places, I've been at places where they allow to keep one family member in, but then we keep the other person on the other side so they don't see anything. So it really varies.
But how big is that needle?
The needle is 10 centimeters long because each person's back can be different. The thickness of the needle needs to be big enough that we can slide a very thin tube in. So
that sounds scary.
So typically, I tell mothers, don't look at the needle.
I don't think I will want to see that.
Yeah. So, but we numb up the skin beforehand with a very, very tiny needle, so that when we do put the bigger needle in, they don't feel any pain, and that's very important to us. And when I do a procedure with any mother, I always talk through what steps I'm going, what to expect, what they're gonna feel, because I know it's very anxiety provoking, and most anesthesiologists, and I think all anesthesiologists do the same. They don't want their patients to be anxious. They want to help with that. That's our job, anxiety, pain relief, all those things.
Right. Eddie, now looking into the future, looking forward, what does the future of labor anesthesia look like?
Well, it's actually quite exciting. Obstetrical anesthesia is, again, like I said, relatively new field, and I think that's the case because we're seeing more and more patients that are coming in with pregnancies that aren't necessarily 100% healthy, with rise in obesity, diagnosis of high blood pressure, diabetes. Those diagnoses can make your pregnancy a lot more complicated, and I think physicians who are more familiar with problems of the pregnant mother are necessary to manage these patients, as well as we have other patients that with such advances in medical care, we see patients who may have in the past died in childhood from these diseases surviving now to the age when they can have children, and they carry very difficult medical histories and things we've never seen before because they are so new. So again, that I think requires someone who's very specifically devoted to that, to take care of these mothers and and they should get pain relief for their labors too, as well. So not just because they're sick, they shouldn't get the same opportunities to have that. So I think that we're going to get more challenging cases, and I think it's going to be a growing and expanding field.
Right. Every challenge comes with innovation, right? Thank you so much, Eddie, for sharing with us all the wonderful insights and tips and stories. Thank you for coming on.
My pleasure.
Show.
I really appreciate it. Thank you.
For the audience watching, we'll see you all next time.